All right. Well, good afternoon, everyone, and welcome to the Ramsey County Board Workshop. This afternoon workshop will be a presentation of the county's opioid response initiative. Today's workshop focuses on Ramsey County response to the opioid epidemic, which it is, and how we are using the opioid settlement funds to address its impact in our community. A courtesy reminder that this board workshop is recorded and it is live streamed on Zoom webinar. So there would be no votes taken during the workshop. So we're going to start with introductions of commissioners and presenters around the table, then the rest of the room. So I am Reen Moran, Ramsey County Commissioner, District 4.
Tara Devon Singh, County Commissioner, District 1.
Mary Jo McGuire, Commissioner, District 2.
Ralph Ortega, Commissioner, District 5.
Mike John, Commissioner, District 6.
Garrison McMurtry, Commissioner, District 3.
Kelly Miller, Commissioner, District 7.
Brady Frank, Deputy Director, Public Health.
Amy Karen, St. Paul Ramsey County Public Health Director.
Nadir Abdi, Deputy County Manager, Health and Wellness Service Team.
Lynn Becker, County Manager.
Okay, why don't we start right here in the front with the pink one? Purple.
Sue Mitchell, the Supervisor of the Opioid Settlement Team in Public Health.
Rahel Douglas, Planning and Evaluation Analysis Opioid Settlement. Sabine Wahira, intern in the opioid settlement team.
Karen Francois, Deputy County Manager for the Community Services and Supports Service Team, and also one of the executive sponsors of the Opioid Response Initiative.
Oh, and Clemens Barrett, I'm your chief clerk team.
Veronica Jackson, I'm the Racing Health Equity Administrator.
Ray Arrell, I'm a communications support for the opioid response initiative.
Kyrie Morgan, communications and public relations.
Ashley Storm, Division Manager for Clinical Services within Public Health.
Eric Levinson, Outreach and Response Supervisor with Clinical Services and Public Health.
Brian Rasmussen, Health Educator, with St. Paul Ramsey County Public Health.
Keep going. B2, Brian Adam, Government Relations.
Matt Freeman, Government Relations.
Christine Hoover, Accountant, Public Health.
Andrew Lowe, Principal Accountant for Public Health.
Lily Wood, Government Relations Director.
Board Reyes, Deputy County Manager for the Safety and Justice Service Team, and also an executive sponsor for this initiative.
Rachel Dixon, Policy and Strategy Intern.
Daniel Levine, Executive Assistant, Health and Wellness Service Team.
Well, thank you, everyone, and welcome. Did we get everyone in here? Oh, I'm sorry.
Janelle White, Controller, Health.
Thank you, welcome. So the opioid epidemic was declared a public health emergency in 2017, and it continues to affect communities across the county. While opioid overdose deaths peaked in 2022 and declined in 2023, they have remained relatively stable through 2025. This reminds us that although we made progress, there is still significant work ahead. Ramsey County is expected to receive more than $26 million in opioid settlement funds through the annual payment through 2022, from 2022 through 2038. These funds represent an important opportunity and a responsibility to invest in strategies that prevent overdose death and address the long-term impact of the opioid crisis. You understood I did that, prevent. Please, nice and loud. During today's workshop, we will hear about the county's response, how we have invested settlement funds to date, and the planned use of funds in the 26-27 budget. The work is evolving, including a new governance structure, stronger coordination across departments, and opportunities for intentional partnerships. Our goal is to maximize the impact of these funds, reduce disparities, and ensure the monies advance meaningful outcomes to our residents, for our residents. The sponsors of the new governance structures are Deputy County Karen Francois, Deputy County Manager Gloria Reyes, the Deputy County Manager Nadir Abi, who's at the table. Thank you. The workshop will be presented by Health and Wellness Deputy County Manager Nadir Abi, Public Health Director Amy Karen, Public Health Deputy Director Ray Eaton Frank, and health educator, Ryan. Who's not here,
Is he-
Ryan Wilson. Okay, Ryan, okay. So, who would like to open? Good dear.
Thank you, Chair. Good afternoon, Chair, Commissioners, County Manager. Thank you for the opportunity to provide an update to the Ramsey County countywide opioid response initiative today. My name is Nadir Abdi, the Deputy County Manager for the Health and Wellness Service Team. We are here this afternoon to give you an update on the county response on the opioid crisis. I'm joined here today as with my colleagues, DCM Gloria Reyes, DCM Francois, who both presented themselves earlier, who along with me make up the executive sponsors for this initiative. I'm also joined here by the Public Health Director, Amy Karen, and Public Health Deputy Director, Ray Eden Frank. During this workshop, we will hear from a staff member, Ryan Rasmussen, about his personal experience, because lived experience is something that we care deeply about, and I feel like it's gonna bring a lot to this conversation that we'll have today. So today's workshop intends to accomplish 4 objectives. 1, to update you on the countywide opioid response initiative, introduce the vision, governance model, guidance principle, and the One Ramsey County approach. The second is to provide an understanding of the opioid crisis and the settlement framework, review the public health emergency, settlement history, and funding structure and requirements. The third is to highlight investments and progress to date, showcase current projects, accomplishments, and impact of the settlement funded initiatives. And the last one is to discuss strategy, direction, and next steps to review the launch activities and funding priorities for the opioid initiative. As Chair Moran stated, the opioid epidemic remains a significant public health challenge that requires a coordinated and countywide response. The opioid settlement funds provide a unique opportunity to strengthen systems, address service gaps, and improve outcomes for residents that are affected by the opioid use disorder. Ramsey County is strategically investing these one-time resources by aligning our efforts across departments and community partners to maximize the impact. Today's discussion provides an opportunity to share our progress and receive the board's feedback as we continue refining our long-term strategy and ensuring responsible stewardship of these resources. With that overview, we'll begin by reviewing the current opioid landscape and settlement framework before highlighting the county's investment, progress to date, and priorities moving forward. Thank you for joining us this afternoon. With that, I will turn it over to Director Karen to take us through these next few slides.
All right, thank you. Good afternoon, Chair, County Commissioners, County Manager. We're really excited to have the opportunity to provide you with an update on the work we're doing to address the opioid crisis. So these next few slides will give some context and background, which I know you're familiar with, but we'll just do a kind of a quick review as to why this initiative is needed. The opioid epidemic was officially declared a public health emergency in 2017 under the U.S. Public Health Service Act. The U.S. Department of Health and Human Services has renewed this declaration every 90 days since, with the most recent renewal dated June 15th of 2026. To help guide our work and make data-informed decisions, we regularly track and analyze information from federal, state, and local data sources. This slide highlights one example. This is health trends across communities in Minnesota, or what we call HTAC. And this is a screenshot of the dashboard, or one of the dashboards on there. The HTAC dashboard includes data on a wide range of health conditions. It summarizes electronic health record data from 11 healthcare systems participating in the Minnesota Electronic Health Record Consortium and is updated each year. The opioid diagnosis data shown here includes Ramsey County residents who received care within the past 3 years and had an opioid-related diagnosis within the past 5 years. As you can see, the map shows Ramsey County by census tract, with darker shades representing a higher number of residents diagnosed with an opioid-related condition between 2020 and 2024. Higher concentrations are visible in several areas of the central, eastern, and southeastern parts of the county. In addition to the mapping diagnosis, we closely monitor two key community outcome measures each year. The first is opioid-involved deaths among Ramsey County residents. This data comes from the Minnesota Department of Health after death certificates have been finalized. The second is non-fatal opioid-involved overdoses among Ramsey County residents who are treated in a hospital or emergency department. This information also comes from the Minnesota Department of Health, utilizing hospital discharge data collected through the Minnesota Hospital Association. Opioid-involved deaths among Ramsey County residents reached their highest level in 2022, with more than 150 deaths. Since then, deaths have declined in both 2023 and 2024, falling to approximately 115. Preliminary data indicates that deaths remain relatively stable in 2025. So we're not there yet. 0 is the number. While overall trends are encouraging, significant disparities also still persist. Black, African American, and American Indian residents continue to experience opioid overdoses at a disproportionately higher rates than other populations, highlighting the need for continued targeted prevention and response efforts.
President Mike Chong and then Commissioner Miller.
May you just explain a little bit more about which communities these are too? Like, I'm definitely familiar with St. Paul, but I can't tell from there if it's like Maplewood or even the middle one, or which community that is.
I don't, okay, there's such an overlay on that.
Which, are you talking about the dark one right
Yeah,
there?
like the right one, the one in the middle and the suburban area. Is that?
I think that would be
Canada?
Roseville, the Rose.
Rose is north of that line.
Wait a minute.
That's north, that's.
It's the north end.
North end, north end of
Oh.
St. Paul.
Oh,
Is that
yeah,
what it
yeah,
is?
yeah, I know where the St. Paul line is.
Wait a minute, I think she back here has the
That's
information.
Little Canada. Little Canada,
Can you share with us?
Little Canada.
Oh, yeah, you share.
Yeah, your
Okay.
question is to clarify the middle part, the corridor. Is that
Mhm.
what you're asking?
Yeah,
for?
yeah, identify like the communities where the dark spots are.
The dark spots are represented mainly in St. Paul, as you can see, downtown and south of downtown, and then east side, and then as well as some shaded area that are dark spots are in Little Canada and part of Maplewood as well to the east, which is zip code 55119.
Got it. Great, thank you.
And we can provide additional description of the maps.
That would be great. Thank you.
Yeah.
Commissioner Miller.
This data is also, I just want to reiterate that this data is only pulled from the individuals who were seen in a hospital, not who were seen by an ambulance or an outside, a provider using a different.
All right.
Okay, thank you.
That would actually get put in an electronic health record, so being seen and being in one of our hospital systems, it's like actually going to the ED and getting admitted.
So if they were to just overdose in an ambulance or a police officer were to come and just Narcan them and they get up and walk away, that's not being accurately reported right here. Okay, thank you for that.
It doesn't, but the deaths would be tracked by our medical examiner or something like that, so those are a little closer, yes, no?
Yes, that's what we got, yes, the death certificates.
Okay, County Manager.
Yeah, Madam Chair, so, to the public health team, there's a nice dashboard and open data portal, if you guys can, as a, add to that follow-up to share with the board the link to that. I think the race data is broken down on the data portal for you, so, thank you.
Yeah.
I'll be back. Thank you. Go ahead.
Okay. So now I'll provide just a brief overview, like I said, just to get with that background of the opioid settlements and how the funding came to Ramsey County. So you can see July 2021, the Minnesota Attorney General joined a $26 billion multi-state settlement with 3 pharmaceutical distributors and 1 opioid manufacturer. Minnesota share totaled more than $300 million to be distributed over 18 years or through 2038. In December of 2021, the Attorney General's office and Minnesota's cities and counties finalized a memorandum of agreement that established how settlement funds would be distributed. So under this agreement, 75% of the funding goes directly to cities and counties, while the other 25% goes to the state to give out their own grants. The MOA also outlines how settlement dollars can be used, requiring investments in opioid remediation activities such as prevention, treatment, and other evidence-based strategies. It also established annual reporting requirements and supports accountability for how the funds are spent. In Minnesota, the MOA also designated public health as the lead agency and chief strategist for coordinating opioid settlement activities. It's a structure that's unique among the other states in United States.
Can I answer questions? We'll go back a little bit to ask where it states that there was a peak in 2022 and a decline in 2023. Why do you think that is? Is it because of Narcan, or what do you think caused that decline and now been pretty stable?
Chair, to answer that question, I mean,
I think that's a question, Chair Commissioners, that has been asked, and I don't know that it's been adequately answered. I think one of the things, there's been a great strides made with naloxone saturation, both within Minnesota, but also across the United States. It's been a really huge push to get naloxone into the hands of everyone who could potentially need it, or who could be with someone who would need it. So that's one part of the puzzle. I don't know that anybody's sort of pinpointed. Yeah, like what the magic bullet is, but definitely naloxone saturation has been a major effort throughout the United States.
All right, Commissioner McBride.
Thank you, Madam Chair. I just want to do a little point of information, because I was on the AMC board when this whole thing was being decided, and Julie Rain just was super instrumental in making sure that counties got a good deal in this. So we just want to thank AMC and Julie Rain, brought in people from all over the country who were doing these settlements, and I think we got one of the best settlements in the country. I think North Carolina got a really good one, and we got a good one, just because we had someone there who was fighting for what counties needed in this, and wouldn't, so someone can correct me if I'm wrong, but I know that it just happened to be Julie Ring just knew this issue really well and was a really good negotiator, and worked with Keith, worked with our Attorney General, and got this to happen. So I just want to give a little kudos to our own people to make this settlement, because every state got different states got different settlements, and you just had to have a really good negotiator this. Just thanks.
Just a reminder of how important it is to have somebody in the room.
And for sure, and to have these partnerships with, organizations that fight for all of us.
Yeah, thank you.
So on the reporting side, those are published each summer, and you can find those on Minnesota Management and Budget Opioid Epidemic Response Spending Dashboard. So that's all out there for the public. Ramsey County began receiving opioid settlement payments in late 2022. In May of that year, in anticipation of receiving those funds, Public Health formed a team and conducted a community-wide survey to determine priorities from the list of allowable uses in the MOA. So later in our presentation, we'll highlight how those funds have been invested to address the opioid epidemic in our community. Then additional settlement agreements have continued to increase the available funding. In December of 2022, the Attorney General joined 5 additional multi-state settlements with 2 opioid manufacturers and the nation's 3 largest retail pharmacy chains. Minnesota's share of those settlements is approximately $243 million. In June of 2025, Minnesota joined another multi-state settlement with Purdue Pharma and the Sackler family, bringing in an estimated $59 million to the state. Then in July of 2025, the Attorney General joined settlements with 8 additional opioid manufacturers. Those agreements are currently awaiting court approval, and if approved, are expected to bring another approximately $9 million more to Minnesota. In October of 2025, Ramsey County created a new governance structure for managing opioid settlement funding. Deputy County Manager Abdi will discuss those changes later in our presentation. So as mentioned, I'm going to turn this over to our esteemed speaker, Ryan Rasmussen, to tell his story and how interventions helped him with his recovery. So we'll do that. You get hot seat. Welcome, Ryan.
Thank you. And I just want to thank everyone for allowing me to spend a few minutes with you this afternoon. My name is Ryan Rasmussen, and I serve as a health educator for St. Paul Ramsey County Public Health. But my history with this county goes back much, much further than just my employment. I was born, raised, and educated right here in Ramsey County. I'm a proud graduate of White Bear Lake High School, and even prouder dad that was able to watch his son cross that same stage just a few weeks ago. And he received his diploma. And beyond a lifelong resident, I'm also a husband and a father to a 3-year-old, as well as my 17-year-old. And on March 4th, just a few months ago of this year, I hit a milestone that required really more grit, more continuing education than any professional certification that I've ever held. I passed 13 years of continuous recovery from opioids. I'm here today as a colleague. I've done news interviews and in radio spots as the subject matter expert on opioids for the county. But today I'd like to move past the data in the spreadsheets. And I really want to come here today to talk about our neighbors. Whether it's the streets that I grew up in White Bear Lake or the busier intersections of Midway, Frogtown, or the East Side. Oh, my 3-year-old. Or the East Side, right? We're in a crisis about managing the restoration of people, of human beings. And right now they look like a lost cause to the systems that we oversee. When we look at the data dashboard from Ramsey County, we see numbers, trends, heat maps. But as a health educator who walks in our communities every day, I see the faces behind those metrics. I see families in suburban living rooms trying to hide their secret that they're too ashamed to talk publicly about. I see people on the street corners in St. Paul who are just trying to survive for another hour. The data tells us where the crisis is, but it can't tell us who's slipping through the cracks. And that's really why I came today, to bridge that gap between administrative policy that gets debated and the human reality that we see on the pavement. In my professional role, I often try to tell people that addiction looks like a series of bad choices, but it's really a biological response to pain. And my own data started back in the St. Paul suburbs, right? I was just a normal kid on a normal middle-class trajectory. I'd like to ride my BMX bike, or you'd find me shooting baskets in my driveway until I was 8 years old. And that's when my parents got divorced. And I was an only child, and that left me vulnerable. And I would experience repeated childhood trauma that would last for years. By 14, I was using drugs as an anesthesia, and I would spend the next 20 years in an active addiction. And looking back now as a public health professional, I see that 14-year-old kid through a different lens. I see a glaring gap in primary prevention. When we talk about the opioid crisis, the conversation almost always revolves around treatment, detox, emergency response, and those are the right conversations to have. We need to have those conversations. But preventing the misuse before it ever has the chance to start. If we can wrap our hands or our arms around vulnerable children and families with upstream resources early on, we can change the trajectory of their lives. When a child experiences trauma or a family unit is fracturing, that is a window for us to intervene with mental health support, stable housing, appropriate community programming. By investing a portion of these settlement funds into primary prevention, we aren't just saving an adult from an overdose later in their life. We're protecting a 14-year-old kid that will never need to use that anesthesia in the first place. But for me, those resources weren't available. And for a long time, I was a high-functioning addict. I owned a small business. I owned a house. I paid my taxes. But when the pain pills wouldn't be enough, I would eventually transition to IV heroin use. And any performance that I was giving the outside world came to a quick end. And I want to be clear about consequences. I went from a small business owner to a man living in a $500 car. I went from a father to losing his son to the county's child protection system. And that's embarrassing, but I'm telling you this because I want you to understand that when we see a resident in the depths of opioid use disorder, they're not bad people. They're just people whose pain is louder than their voice of hope. When I finally crashed into our county system 13 years ago, I hit two very different doors. The first one I hit was a state police officer. I got pulled over in North Minneapolis, car full of people. Got my tickets. I think I got my 8th of 9 driving on a revocated license that night. So he wrote me my tickets, but he'd asked me to step out of the car, so I assumed I was getting arrested again. But that officer looked at me, not as a criminal to be processed, right? He chose to see the humanity instead of my rap sheet. In a system that so often penalizes addiction, he met me with compassion. He asked me to step out of the car and have a conversation with him. And he told me that I looked like I was dying. He also told me that there were hospitals in the metro that could help me get off of the drugs. And that was a door opening. When I would get to the hospital, when I finally reached the hospital, I got met with a wall, I went to a medical detox, shivering in withdrawal, and I did a chemical health assessment with the administrator. And that administrator would deny me a bed. She looked at me and told me that I was just homeless and trying to get out of the Minnesota cold. And that's not what they did there. I was being triaged based on my appearance, not my medical needs. So even to be considered for admission at the hospital that I went to, I had to go through an emergency room first and get a physical examination to make sure my body was strong enough to withstand the severe strain of opioid withdrawal. That administrator had already written me off, but the doctor who performed that clearance physical saw past the surface. He didn't have a bed available for me in their detox unit that day, but he stopped me before I was able to hit the streets again. And he looked at me and he asked me to do him a favor, survive one more week, just 1 week, and come back, and he promised to have a bed for me. That 1 more week wasn't just a clinical delay. From a first person perspective, it was the first time in 20 years that someone had placed a bet on my future. When we talk about these settlement dollars, with the leadership in this room, we hold the pen to the county's future. What we are really funding is an infrastructure of hope. I believe that hope is a clinical necessity. It's the bridge between a resident deciding to pick up a needle or pick up the phone and ask for help. By investing these dollars into accessible, low barrier services, the leadership is making a declaration to every human being in Ramsey County that 1 more week is worth it, that we're buying time for their brain to heal and the resident to believe the doctor instead of the skeptic. In our current system, we lose too many people during that week gap. When a person reaches out for help, their window of willingness to change is incredibly small. Sometimes it can just last a few hours. If our answer from the county is, hey, fill out some paperwork and we'll call you, right? We've effectively closed the door on them. The infrastructure we build with settlement dollars must be designed to capture that exact moment of clarity. We need low barrier entry points. If a bed isn't available today, we can do a warm handoff, offer peer support, or harm reduction supplies so we can keep them alive until we can get a bed. And I did what that doctor asked. I survived that week, and it was a hell of a week. And I came back, and I was finally admitted into medical detox. And that's really where my medical journey would begin. They would start me on Suboxone, which finally allowed my brain chemistry to stabilize enough to even think about a future for myself. On the 4th day I was in medical detox, I was in a locked unit. I'd been running from child protection for months, and they weren't real happy to meet with me. But I was weak and I was vulnerable. And for the first time in 7 years, I was 4 days sober. So I met with child protection. My worker came to the little dining area, maybe 5 tables in this little detox unit. And she had papers laid out, and I'd signed papers. The last paper I signed was losing temporary custody of my 4-year-old to the county. We finished the paperwork. I walked her back to the front door. She opened the door, turned around and looked at me. And she told me that we're going to start the process to take your parental rights because people like you don't recover. That's what she told me. That's with me today. And I turned around and I walked back into my room. I closed that thin curtain that separated me from my roommate. And I sat down on the edge of my bed and I cried. It was a dark moment. I knew I was a bad father, but the real devastating part was that I was sitting in that locked unit because I was finally ready to start a process of change. The system was giving up on me exactly when I was trying to save my own life. But she was wrong. It would take me 10 months of relentless, grueling work, but I did what she would tell me would be impossible, and I got my son back, and I would gain full custody of him. And he just graduated. That's the one that just graduated. I'm living proof of what, thank you. I'm living proof of what happens when raw internal motivation meets appropriate external services. For 20 years, I had that motivation. It was there. I wanted to stop every single day, but the services were absent, or I felt I couldn't access them because of negative stigma. I'm a success because for one brief window 13 years ago, my desire for change was met with the resources. Our job with settlement funds is to ensure that residents' worst day is met with the county's best resources, turning that moment of clarity in their life into a lifetime of recovery. This requires us to break down silos within our own government. When I was going through this 13 years ago, the medical system, the corrections system, the child protection system were all disconnected. The left hand would never know what the right hand was doing. While the doctor was trying to save me, the social worker was writing me off as a failure. We can't afford to run a fragmented system. Lived experience teaches us that if we want to maximize the return on investment of these settlement dollars, our public health initiatives must be woven directly into our jails, our courts, and our family services. When a resident encounters any department in Ramsey County, they should experience a unified front of support, not a conflicting set of rules that leaves them feeling defeated. And I'm often told that my story is miraculous, and maybe to my kids it is, and my poor parents that had to live through this with me, maybe I'm a miracle, right? But from a systemic point of view, I don't think so. We can't replicate miracles, but if I'm a result of appropriate services, we can fund those services. My recovery followed a really predictable path, an evidence-based path: detox, medication, inpatient treatment, long-term outpatient support. The reason that I'm here with you guys today, the lifelong resident and graduate of our schools, is that a resource was there when I went back to the hospital a week later. My son has a father today because the system did do its job. Every person currently struggling in our county is a potential homeowner, potential taxpayer, a potential father or parent who just hasn't made it home yet. As the leaders who oversee the settlement, I'm asking you to fund compassion that proves all the skeptics wrong. My real job the last 13 years, the one that I've worked every day on, is being a man who broke a really challenging cycle. And as the stewards of the settlement, we have a heavy and historic responsibility. I came here today to make sure the board has not only the data, but a frontline perspective on how to help the next resident have the same opportunities that I've had. Thank you. I appreciate the few minutes.
Wow. Oh, we're so lucky to not have you here.
Yes.
Powerful
thank you.
testimony.
Thank you.
Wow.
This is not the first time I heard that story,
Mhm.
and it gets me emotional every time
Mhm.
because you can tell
Yes.
what Ryan went through and what many Ryans that are out
Yeah.
there are going through. So part of this workshop is not just to share the data, the infrastructure, how we're doing things, but also the lived experience and the people that are actually suffering behind the scene here. So thank you for allowing that today.
Mhm.
And thank you so much for your
Yeah.
bravery for sharing.
Yeah.
Okay, so
It's hard to get back to
All
that.
right. with that, who would like to,
All right.
please, my.
I am back on.
Okay.
This slide shows total opioid settlement funding currently expected over the life of the settlement. So, back to our dollars. For comparison, we've also included the projected funding amounts for Hennepin County and the city of Minneapolis up here. Settlement payments, as we said, are in annual installments over 18-year period up through 2038. So these totals don't include any of the interest earned because we've had some funds that we have not spent, and those are earning interest as they're sitting there. So in addition to Ramsey County, 4 cities within the county also receive opioid settlement funds directly. Under the MOA, cities qualify for direct funding if they meet specific criteria, such as filing their own opioid lawsuit, operating a public health department, or having a population of more than 30,000. The MOA also requires each county to hold an annual meeting with all cities in the county to discuss the use of opioid settlement funds and opportunities for coordination. So we have done that this year. And we met in April and had a really great turnout. We continue to work with the cities to receive settlement funds to identify opportunities for collaboration and to really maximize that impact of these investments across our communities.
A question, Commissioner Jefferson.
Yes, my question on that is there's collaboration and coordination. I'm just curious, how much of that is educational just to keep you, so you're learning together, and how much of that is a collective effort where you're specifically, working on things as a collaborative? Does that make sense?
Mhm.
I mean, there's like, okay, I know what Roseville's doing, maybe I'll learn something versus no, actually, we're trying to leverage everything in a very concerted way.
Right, so Chair, yes, that's a really great question. I would say a mix of both. We do want to learn from each other. We want to learn what others are doing across the state and nationally, as we've talked. But we also get together and we don't just meet with them once a year. We do collectively, but we do have partnerships with each city or with some of the cities along the way. So in some upcoming slides, you'll see where we've kind of partnershiped with some of the cities on some of our efforts. So
And there's definitely some ongoing conversations, current conversations that are happening.
Yes.
So that we don't really have specifics about, but that are underway.
I appreciate that, and and that clarification, having been in a lot of collaborative spaces, I value all of those potential ways that you can be working with folks, but given that we have overlapping populations, overlapping systems of care, overlapping providers and other trusted messengers and things like that, so that we are, making sure not to overlap, to be repetitive and to have gaps. So I appreciate that.
Yeah. Thank you.
And I would say, I'll add to that too, not beyond our partnerships with the cities, things like partnering with regions and some of those places too, like our major places where we would have this population intersecting, so, yeah.
Madam Chair,
Mrs. Owen.
just a quick question, and because of the cities that have also received their funding, I'm curious what the conversations have been like then with those specific jurisdictions. And if you'll be going through that later in the slide here.
Yeah, so Chair, County Commissioner, yes, we will be going through some of that later on. I don't have that off the top of my head, like specific conversations. I just know like really in the last 6 months, we've had even a ramped up effort over this too, because as these cities are kind of talking about, many of them have not used a lot of their funds. And so as these cities are talking about that, we want to make sure we're in some of those conversations. So we don't duplicate efforts. We are making sure we're doing a collaborative effort, because that just makes sense.
Yeah,
I mean,
definitely.
County Manager.
Yeah, so, commissioners, good questions. I think for those of you who serve on the Joint Property Tax Advisory Committee, you're probably having the same thoughts that I am. I've been talking to the city of St. Paul in particular. I mean, this is where you all can be helpful too, as you are talking to your counterparts, elected officials. Like this is St. Paul, Ramsey County Public Health is actually a joint venture, and we should be pushing the conversation of how to use our resources probably in a non-duplicative and supportive way. I'm sure, both organizations have some ideas of how they want to spend the money, but we should be getting in a room and talking about that collectively. We certainly talked about this open JPA idea at that meeting. So I just want to make sure that could be applied in these kind of spaces. I know when the city of Maplewood got some MAHA, I'll give an example. They came out to our CED department, so I think like these cities are starting to see that sometimes I don't know if the juice isn't worth the squeeze, like the amount of administration, especially for some of the smaller cities, they might be looking to the county for some support, if that makes sense. And overall, I guess I don't want to just say St. Paul, we are the public health department of the whole county. And so there is some efficiencies potentially that we should keep pushing on, if that makes sense.
Yeah.
Yeah.
Just to wrap my thought around that too, which I appreciate, and definitely along those lines. I'm also thinking about our alternative response initiatives, a recent contract that we had with Maplewood about community responders. That it aligns with, the story that, we just heard right from Ryan about like that those crucial points and moments are very critical to supporting people. And I heard about mental health, housing stability, wraparound supports for families, that moving upstream is required. That the work that we are doing encompasses all that as well. And so how do we coordinate these funds in that fashion, along with these cities that have also received opioid dollars and that have also been impacted by the opioid crisis?
Okay, Commissioner Garrison.
Thank you, Madam Chair. No, and it's kind of to piggyback off of what Commissioner Zong mentioned. I was wondering what exactly were the guidelines, what these funds could be used for, and if there are other areas that maybe we haven't been utilizing before, but we know are directly impacted by the opioid epidemic that we should be thinking about using in the future. So I don't know if you have a response to that, if there's something.
I think you're gonna see it soon, because we sort of embedded it in the budget.
Okay.
It's the very next,
Yeah, hopefully we can demonstrate.
Yeah.
And then my only follow-up, and I think you'll be mentioning this in the next slide, but do we know how much for the city of St. Paul they have remaining out of their 14 million in settlement funds? Do we know that? Okay.
It's okay.
It would be premature to assume they have anything remaining of 14 million. The 14 million is gone over all those years, right? So they don't actually have 14 million ever in the bank ever at one time. And neither do we. We don't have 26, if that makes.
Yeah. Commissioner Miller.
Off of that point, how much do we have in the bank, or how much have we had in the bank? Is that the next slide? Like, I did see, I'm looking at it. Okay.
Segue.
I was on you, but.
Okay, so this is a screenshot of a new dashboard that we've that our accounting has been putting together for us. So this will be up and running soon. But this will just show you a glimpse of our opioid funding dashboard. So to date, we've received 11.1 million. Our total projected revenue by the end of 2027 is 14.5 million. So of this, we've spent 2.1 million to date, and then anticipate total expenditures of 5.4 million by the end of 2027. So we expect to receive another 2.9 million in 2026 and 27. That'll give us approximately 9.1 million in uncommitted funds at the end of 2027. So we have 9.1 million to work with now that has not been committed or for ongoing things, if that makes sense.
Are you able to share what you're spending dollars on?
Sure, yes,
Okay.
yes.
Is that on the side?
Yes.
Okay. Commissioner Jefferson.
Yeah, I just have some dollar questions. One is, how long, is there a limit as to when we have to spend down these dollars?
Of limit?
Yeah, I mean, like, is there, like, are these
2038.
is the 2038 what
That's the
the,
last payment.
that's the last payment,
payment,
but is
right.
there a time when I mean, are we obligated to spend it by a certain?
It's not like a grant. It's a
Yeah, no,
Oh, it's a settlement.
yeah.
So, and so there's no minimum or maximum. That would be for us to decide how best to
Right.
invest these funds in our community.
Yes.
And then I guess this is quite a large amount, and I guess, I'd be curious to see if we've thought about, setting aside or like some kind of a portion of it as an endowment so that the interest would be ongoing for, ongoing thing. I don't know. That would be more of a finance question, but the idea of being able to be able to figure out, because one of the things that we know about addiction is that there will always be another way of alleviating pain, another chemical that will hit our streets, that will hit our communities, and that may not be attached to wealthy corporate entities that we can sue for these kinds of funds. And pain is pain and addiction is addiction. So there's a part of me that wants to make sure if we have the capacity to be doing these upstream things, it may or may not be specifically an opioid addiction that we are preventing, but another just as devastating to an individual and their family and our community, whatever's coming around the corner. So this is just something I'm curious to hear more about as we think about such large chunks of money, and knowing that these are one-time funds, even though they're large amounts of funds, but these are evergreen community issues.
Thank you.
Okay.
So this bar graph on the right, that shows the anticipated revenue per year. As mentioned earlier, distributions are expected as additional lawsuits are settled. So we don't always know the specific dollar amounts on those, so we're just projecting that right now. So next, I'm gonna turn it over to Deputy Director Frank to share highlights of projects from our 2022-2025 timeframe.
Thank you.
Thank you.
Thank you, Director Karen. Good afternoon, County Manager Becker, Chair, Commissioners. It's really my pleasure to be here. I'm hoping that these next couple of slides will answer some of the questions that you've had. I'm sure there'll probably still be some holes, but we'll try to fill those. I also want to give a little bit of context because Ramsey County didn't just start being concerned about the opioid epidemic in 2022 when these settlements happened. We've had a long-standing commitment to our residents and to addressing issues of these kind. And so some of the monies that we have, the programs that we've had and the monies have been from other sources, state sources and federal sources, for example. So this is a mixture of both opioid settlements and also state and federal grants, and also some internal county budget funding. So just it can get a little bit confusing, but we wanted to give you a picture of the opioid response, all inclusive of many different funding sources. One of them that I want to highlight is that in 2019, within community corrections and correctional health, we began giving daily buprenorphine, which is also Suboxone, which is what Brian mentioned. That's the brand name is Suboxone. So we began giving that in our community corrections, both the Ramsey County Correctional Facility and the Adult Detention Center. And we've been giving that now since 2019. That's been an ongoing initiative. from multiple different funding sources. So currently, initially, it was kind of kicked off with the DHS funding, so some state funding. Right now, we have a SAMHSA grant, which is what pays for the staff for that. And then also the cost for the medication itself came out of the correctional health budget, and that's what's outlined on the slide, that 91,000. And that was actually just for a 3-year period of time. So another program that's not on the slide, but did not receive settlement funding during this time frame, is the Syringe Services Program, which was opened in 2019 with support from the Minnesota Department of Health, and we'll talk about that more later on our current funding.
So I have a question about the Suboxone, which
Yes.
is a way to wean people, an individual off of the opioids, right? And it happens within our jails. But then when they are released, what does that look like? Does that follow them so that they can have access to the Suboxone, and are we using it in other ways?
Yes, so some of this we'll get into a further slide, but I can share it now because they are tied together. One of the innovations in science has been the development of an extended release buprenorphine, goes by the brand name Sublocade or Brixada. And Suboxone you have to give daily. So someone has to be somewhere where they can be given a daily dose. With the extended release, there is actually a 30-day extended release. And so an individual is given that medication and they have 30 days. And so we have instituted that in 2025. We gave our first 2 doses, and now that's something that we've implemented in our Ramsey County Correctional Facility and Adult Detention Center. So as people, as they're leaving, they're given that dose, and then there's a month period of time, which gives people a little bit, they don't have to find a dose the next day. And so that's one of the ways we're trying to address that, so that we're able to give people some supports and some mechanisms so they can be addressed during that monthly period. And then we have other wraparound services that can help them get connected either to a doctor or to where they can get the prescription.
Okay, so Ramsey County does not continue
We don't.
with that
Good
individual,
question. We do not continue, no.
so they have to.
They have to find a community resource. Yeah.
And what does that look like?
Does it look like?
Yeah, a community resource, is that, I mean, Suboxone is a program, right? I mean, it's a service. So are there like nonprofit organizations that?
It's through doctors, so it's a little bit different than the methadone. So methadone, which was the standard of care for a long, long time. Those were given specifically at a clinic, and only clinics that were specifically licensed to be able to provide methadone could give those. Suboxone can be administered by doctors, and so it's a little bit more readily accessible.
Do you connect them with?
And we do some of
the
that
doctor,
connections,
the
yeah.
hospital?
Yep, yeah, we do. But Ramsey County as an entity doesn't have like a daily clinic or doesn't have a doctor that can prescribe it once a person is outside of our correctional
Is there a
facility.
cost associated with that?
Yes.
How much does it cost?
So Suboxone, the daily dose is, I just got this $13 a dose, something like that. It's very, very, so the Suboxone is very,
Affordable.
it's affordable. Sublocade is much more expensive. And we're talking about for the extended release between $1,400 and $2,100 a dose.
Wow.
There's also a weekly dose of Brixada, which is about $400, but still that's $1,600 a month. So that's a big, huge barrier is the cost.
So what's the difference between the Suboxone and those other 2 you named? Do they all do the
So
same
they're
thing
all
for 30
Suboxone.
days?
Yep, they're all
So,
Suboxone.
14, whatever.
One of them is 1 day, there's a 7-day, and then there's a 30-day.
And the cost is connected with that.
Yes.
Commissioner Miller.
For the 2, I'm just curious, for the 2 individuals that you gave the longer dose to as they were leaving our facilities, has any of our team followed back up to see if they've received the help that they need? I mean, just to follow up to see if, hey, yeah, this really helped me and it helped change my life, right?
Yeah.
I mean, and it worked, and now I'm successfully on a program, I have insurance, and I'm, working towards, maintaining the sobriety.
Yep, and so actually, I don't know, so Ryan is actually one of our health educators and staff people that works in the RCCF and the adult detention center offering groups.
Yeah.
Along with a nurse practitioner who is the one that actually does the assessments and is administering the medication. So I know I don't think Shelley's here. I'd asked her for some success stories. Okay, good.
Good for Shelley.
Yes.
So we see, once we get those initial 2, to let you know.
Yeah.
We try to follow up, we connect with an outside resource. I think one of the perceptions that we have working in corrections is we're seen as part of corrections. So
Yeah.
when a person leaves there, they're not
I don't want
super
nothing to do
excited
with you,
they
right?
we can talk about public health all day long, we're still perceived as part of that. So we do have some communication barriers from the people leaving. But what we do know is from those initial 2 shots, how many have we given out, right? I mean, dozens and dozens, like it goes around.
140, yeah,
140
or
a
something.
year later.
Yeah.
So it's a better, for that circumstance, every time somebody gets moved in corrections, it's a safety issue. So now instead of moving someone once a day, we're moving once every 28 days, so the facility's safer. But then they don't have to dose every day, because when they leave, like Ray was saying, they don't have to go find a clinic the next day, we send them out the 2-week prescription, you know what I mean? So they got 28 days, but they also have 28 days of overdose protection.
Yeah.
The buprenorphine is a partial antagonist, which offers significant protection against overdose. People leaving corrections are 40 times more likely to overdose than the population, so that's a big reason why we push so hard to get that money.
And then a quick follow-up, do we have individuals that have refused that type of care as well?
Yes,
Okay,
yes. Yeah, less stigma around buprenorphine.
yeah,
Transitioning one drug to another.
right.
That's true. We try to do education. Everyone that's received Sublocade, I've met with and had a conversation with.
Okay.
But yeah, some people want to go back out and use, that's a reality of addiction.
Yeah.
They don't want, they're not ready yet, not their time.
Yeah, and thank you, Madam Chair. So I appreciated, Ryan, one thing I wrote down that you said was kind of an appropriate set of external services, like the best resources to the right desire to change, so I just really want to challenge our team, like, it feels like that moment wherever that is happening. And I think we have some of the people in the room, but I think, maybe a few of the sponsors can reach back out to. It feels like this is the moment we should figure out, like, what type of mental health assessment are there emergency assistance, is there housing, like, it is a moment of county wraparound
Yeah.
opportunity. And so if there's a pilot that we could think about to sort of like put a care team around that, it feels like it's the right moment that we don't want to lose. Because I've also thought when I was in the workforce department, like sometimes people would leave the correctional facility and be like, oh, well, you gotta just find your way to like, and then you get handed a folder, right? So how do they immediately walk out? They have the medication, but they also get a county navigator like Mayo Clinic to be like helping them get whatever things that they need in terms of navigation, right? So I think that's what could kind of be the elevated moment that we could provide. So I'll just throw that out there.
Okay. I also heard Brian said that once they leave the jail, they have to find, and like, can we create a partnership with, I don't know, a clinic here, a clinic there, something that is, when you're dealing with all that you're dealing with, trying to find something can be very difficult and just sometimes triggers a lot of other things. So maybe we want to be on that prevention side, that's an opportunity to go upstream a little bit and say, this is where, we have a partnership here, you can go here for your next dose, which is 28 days later, but it's there.
Thinking of that, and I love that idea, but I'm curious to know when they're leaving our facilities, whether it's the ADC, whether it's the RCCCF, are they still under terms of probation? And how is that something probation can lean in and help with some of those supports as well? I think of like when you leave the DOC, right? All the resources you get and you still have that person you have to be in contact with to be held accountable. So how do we kind of do that at another level here to help them? Because I 1,000% agree, like you get out of a facility and you have this great resource now to keep you sober and to help you not die. But now you also know you have a time limit, like, oh shoot, I have either 28 days to change my life and start working towards that, or I have 28 days till this wears off and I can go get high again, right? So I think, it's really critical that we offer those supports and resources in that time frame.
Commissioner Jefferson.
Well, I will just say I'm really interested in hearing the breadth of the different programs that we have alongside this moment of interruption when somebody comes in and out of our care and custody through the adult detention center or the correctional facility, because, for somebody who has this illness and they come into a moment of being arrested and going through that process, a lot of wheels of their life are coming off in that moment. And the idea of like, now's the time that I'm gonna have the internal resources to make the decision to go through the journey of recovery at that moment may be more along the, I gotta get back to work. And I gotta, you know, whatever. I mean, there's a lot of other moments in somebody's life that will pull into prevention of this. So I don't want us to go too much down that one specific interruption in somebody's life when we have multitudes of opportunities to create intercepts that might along with that.
Okay, we're gonna try to get through some more of these slides. We've done 4.
Yeah, I had a quick question on that on the one, on the naloxone training.
Yes.
Okay, so having been in community during this time, I remember a lot of work to get the naloxone out, to get it educated. There were a lot of concentrated efforts, much I'm sure that you were part of to get through in many different communities and all those kinds of things. Now that this becomes something that I think almost everybody is aware of this, and it's, you know, we've kind of gotten to that point. Is this something that you see as waning as far as like that, you know, the inoculation is of getting supplies out there, or other people who are backfilling? Has it become kind of a norm, kind of, you know, or is this something that will still have to have a certain pressure point from us specifically in this realm?
Yeah, there's a lot of organizations that are doing naloxone education and distribution, as you just suggested. I will highlight one partnership that we have with the Steve Rumbler Hope Foundation, because they have a mailing program where anybody in the state can go on their website and they can be mailed a intramuscular dose of naloxone. We wanted to make nasal Narcan or naloxone available to Ramsey County residents, because a lot of people don't want to do the IM, they'd rather do the nasal. Because of the cost, Steve Rumbler wasn't doing that, and so we partnered with them, and we're helping them so that if you're a Ramsey County resident, you go on their website, you can actually order, you can have your choice. So that's one example where we're kind of filling a gap, but we're not doing mailings ourselves, because there's already an organization that's doing a good job, has the infrastructure to do it. There are still other organizations that are doing training. We do still get requests to do trainings, and we'll do them because we don't get a whole lot of them. I just got an email yesterday for somebody who's looking for naloxone, and so I referred him to Steve Rumbler because there are naloxone access points, you know, whatever closest to him. He can come to us, but he doesn't have to. So we're one of many resources.
Yeah, I mean, I think in some ways it's not too dissimilar to that first rush of 18 months of learning about PPE, and now you can go into Walgreens and everybody knows to get a mask if you've got a cold.
Right, yeah.
That's just.
Yeah.
Right.
And I'll just mention too, through our syringe services program, I mean, we're still passing off naloxone and the nasal and things like that. So to specific populations. Yeah.
So just real quickly, I won't go through all that. There are some things, this is the team, and most of the folks are from who've been working on this are in the room. And some of the things that we've done behind the scenes, I just wanted to give a little quick overview of that. We do have annual reporting, as was stated, so we're completing that annual report every single year. And then you can find that up on the Minnesota Management and Budget Opioid Epidemic Response Spending Dashboard. So that's something that we're continually doing behind the scenes. We're the required annual meeting with the municipalities. We've done every year since the MOA was created. This picture is from our last one, which was in April. It was actually the first one that was in person, and so there was some questions that were coming up about collaborations, and I think this meeting really it would help. The first couple of meetings, it was during COVID, they were online. One was going to be in person. A snowstorm happened, so we did it online. So anyways, this is the first opportunity that we got together in person, and I want to say it was very, very valuable, because some of those conversations that don't necessarily happen organically when you're online really were happening between staff and city staff about how can we collaborate, how can we move forward. So a lot of that brainstorming really kind of jump started at this meeting that we had in April. So now the next couple of slides are some of the current things that we're funding. And I'll just, I can just be very, very brief. I can read more specifically, but the harm reduction supply cabinets are something that we have funded to get. Again, this is another way of getting naloxone and some of these other supplies out into the community. So we have them at a number of different community centers. They're just basically cabinets, and then with supplies. We're also currently working on a vending machine solicitation. I think that folks have had a lot of interest in that. There's a lot of communities around the state and also nationally. They're literally vending machines. They're free and they're full of naloxone and other harm reduction supplies. So we're working on a solicitation so that a community organization can buy and supply and manage that vending machine. So that's in the works. We partnered with the St. Paul Fire Department First Responders. We funded the purchase and deployment of many essential supplies. And this really helped them to really enhance their life-saving interventions for people experiencing opioid overdoses. So this was $20,000 in one-time funding. And then we also assisted in getting supplies out to other fire departments throughout the county. Next slide.
Oh, Commissioner.
Oh, yeah.
Quick question on just the funding piece, because we know for a number of different grants or federal funds that we get as a county, at times, City of St. Paul also gets that funding, and so in that we split, well, maybe we will not do that for the City of St. Paul, but we will for suburban Ramsey County. How does that work with the opioid supplement funding of us, providing funds for the fire department? Would that be something that they could tap into their own funds for versus us providing those funds?
That's exactly the conversation that we were having earlier and are continuing to have. And I think some of it is because these funds have been around since 2022. So in some ways you can say, well, that's 4 years. And really it's, it's just been a blink. And so municipalities and jurisdictions are really getting used to like, how do we spend the money? How do we best partnership? And as we know, within some of the different, even, we're really working on this one Ramsey initiative of like, working out all our departments together, but there's also a lot of siloing that goes on. And so within St. Paul, I don't really know what sort of like the backstory is. And this relationship, we started with them a number of years ago. And I know they've had staff turnover and different leadership turnover of their opioid settlement funds. And so I think some of that is just those conversations that are now really happening and bringing things together. But at the time when we had this conversation with them, they weren't able to utilize their opioid settlement funds for it. It was in a different area of the city, and we were able to provide something that they weren't able to get in another area.
That's helpful. And so I'm wondering, as the City of St. Paul in particular kind of start getting their ducks in a row, are there new processes or guidelines that we need to set on our end of, a percentage of amount that goes for the City of St. Paul? Is it still going to be mostly open that if they apply or they need assistance, that we will help them, even if they have not utilized their existing funds yet?
Yeah, I mean, these are great questions. And I think one of the Deputy County Manager Abdi will be sharing about a new structure and a community or an internal advisory board that we have that is addressing and looking at those exact type of questions.
Madam Chair, I do think, Commissioner McMurtry, this does require a leadership conversation. We've had an administration change. I think, I appreciate staff at all levels and different departments trying to find ways to collaborate, but really some of these decisions and vision and direction need to be set based around all things we were talking about reducing our property tax pressure. I mean, the city has a $26 million gap that they've been talking about. So I just feel like we need to I'm going to have those conversations with one of the assistant mayors who oversees the opioid funds. But I think, like I said, I do think you as elected officials have some ability to talk to the mayor's office and to talk to city council members, say, maybe the way of doing business as usual in two different tracks is something we got to come to some shared aligned vision. Are there some, and we've been trying to do that in different spaces, but it needs your leadership as well. So thank you.
Well, and I just add too, one of the things when I was talking about the naloxone too, and thinking about this kind of support for the fire department is just like the defibrillator machines, other kind of things. Once, some of these programs are just making sure that there's somebody locally who decides, along with the other ways that they're supporting their local programs, say, we're gonna have $5,000 that we dedicate towards this instead of that. That doesn't necessarily require a higher level coordination of skills and programs and interventions that maybe we as the county are uniquely poised to do, where somebody else can say, yeah, we can come with a big check. The Lions Club can say, this is gonna be part of it, along with the hearing aids and the other things that they do. So that's what I was just trying to say, is that how can we uniquely do the things that we can uniquely do? And then draw people in to do the things that they have the capacity to do, so that we can focus on the things that only we can. I guess that was kind of my question. Was not that there won't ever always be a need for these kind of medications and services and harm reduction things within our communities, but at some point the education level is there that somebody else, we can pass that on to them.
Okay, let's move forward.
All right, very, very brief. I'll just give a few highlights. This is another one of our partnerships with Second Judicial Court and Justice Point at the Ramsey County Treatment Court. So the Adult Substance Abuse Court, the Driving While Impaired Court, the Veterans Court, and the Mental Health Court. We provide support for Justice Point to be able to provide pretrial case management. You can go sit in on these drug court sessions. They're incredibly impactful. If you ever have a couple hours to go and sit and watch and the interactions between the judge and the participants, it's really amazing. He's incredibly caring, listens to their stories, similar stories to like Ryan shares, but people who are in it. And then the judge helping them support them with resources rather than go to jail, finding other ways and other paths forward.
Really quick question. Just the idea says up to 55 people. Is there a waiting list? I mean, is there a robustness as far as use of this program or need for this program?
There's
beyond,
definitely a need for this program. I don't know that there's a waiting list now. There's not,
Okay.
55 has been pretty stable.
Okay, that's good to know.
Yeah.
Okay, thank you for that. I was just curious.
Next slide. We basically talked about this. This is the extended release buprenorphine, which we're now providing at the correctional facility and the detention center. Both Ryan and Kyle, who's not here with us today, but they are staff who are in the facilities providing groups and support for the individuals who are being given this medication. And then we also have Shelley Thone, who's our nurse practitioner who is doing the assessments and also part of that program. So I think that we talked about that, and so we can move to the next one.
So I have a question on this. So we are trying to get a partnership with Regent Hospital.
Can you go back
And so we're given, so budget, right? So yeah, talk more about this.
Yeah. So Regents Hospital is really interested in a partnership with St. Paul and Ramsey County. Because they have an emergency room where they're seeing a lot of people come in. And they would like to be able to, they're sort of in a similar situation where they can give the Suboxone because it's cost effective. But there's a national program called Bridge or Bridging, which is providing, it's kind of like this bridge of services. And so there's a clinic in Minneapolis, I think it's through Fairview, that is doing this clinic where they're an emergency department and then they're giving folks the Brixadi, which is either the 1 week or the 30-day. And so Regions is really interested in that model and being able to provide that, but it's a pinch point at $1,400 to $2,100 a dose. They're really struggling to figure out how that they can.
We're gonna do it.
Right, yes. Yeah.
At that cost.
So.
No, I was just gonna say, Chair and Commissioners, so part of this conversation is also the partnership that we're trying to develop with City of St. Paul and the new leadership. So we're trying to figure out how we could do this together, if there's a possibility, because we can't bear the cost all of on our own. So there's conversations that are taking place and we're figuring things out. But we're hoping that some sort of collaboration partnership will take place between the county and the city.
You want to do it, Commissioner John first? Yeah.
Thank you. Yeah, my question around with Regions is, for the population that they are seeing in the emergency room, like, wouldn't they also be able to get Medicaid, to pay for it? And if there's like a gap, like, couldn't we figure out a way to get those clients, processed and approved for medical assistance?
That is exactly what they're running into. So with those first doses, if they're just coming in the emergency department, they can't fill for those. For some,
they can't bill.
There's an administrative barrier that they're having.
So if they came in inpatient, they could. So we're trying to kind of get a good understanding of that too. So it's those first doses, they can't, it's straight out of pocket for them.
Federal or state barrier.
I think it's probably a federal barrier.
It could be like retroactive, like from the date that they apply.
That's a federal barrier. It has to do. It's kind of complicated. The hospitals are financed through the drug companies to get, or I don't know, you wouldn't call it charity care, but to subsidize healthcare and drugs. And those, that's where some of the restrict. So if you're in the emergency room, you got one set of rules. If you're in the, if you're staying overnight inpatient, you got another set of rules.
My question was exactly your question on getting insurance to pay for it. Is the issue that they're running in with is don't have insurance or people do have insurance? Or is it both? I mean, I'm sure it's a combination of both, but either way, they would have to be admitted as an inpatient to have it be covered. Okay,
Yep, that's the pain point right there. Yep.
yeah.
All right.
All right, really quickly, the next two slides so I can hand it over. The syringe services program we've been providing this service since 2019. We had state funding to do that. That state funding ended actually in June of 2026. We had very short notice that because of some policy changes, we were no longer going to be receiving funding for the state for a syringe exchange. And so settlement funds have agreed to be utilized for that program for a 1-year period of time, while we can look for other funding sources for that. Yes.
And is this affected by the federal's change in harm mitigation dollars, or is this separate than that?
We think so.
So some of the communication we have gotten has been very unclear, or we've been communicated and then been told different things. So I don't know that I can answer that
Because
question.
it would have been federal dollars filtered through the state, so it's our
Yeah.
communication through the state on that.
Yeah,
Yeah.
yeah.
So is the syringe exchange is where the barrier is, or these other I don't know.
So it's specifically the syringe exchange. I mean, that's predominant. Harm reduction as a sort of general service model is not, I don't think, palatable to this current administration. And so the things
Think what syringe costs. Can you get that in bundles or something?
Oh, they don't,
Syringe? It
yeah.
shouldn't be a high cost for us to be able to carry that. Is it?
Yeah, good question. I don't actually know how much a syringe costs.
Syringe.
Yeah.
So this is staffing.
It's the
Yes.
program, it's the programming.
It's the whole program.
Yeah.
For someone to come and say, give me a syringe, or to exchange syringe? or-
Exchange, so we take.
And then there's also the disposal, and we have to have,
It's more than just giving them needles. There's.
Yeah,
there's-
But that's
there's
how
like,
It's in a team of 4.
yeah,
It's a whole prevention piece there.
Yeah.
exactly.
Right? And we gotta go upstream
Right.
and to invest in some, cause a lot of this is not even prevention that we're doing here right now. It's trying to maintain, or someone overdose, we're using the Narcans to bring them back.
Preventing deaths.
Right, we're preventing death, we're not preventing a high. They get up and they die 5 times in one day,
yeah.
right? And so, I mean, the syringe is a prevention piece there. I'm just saying, we can just.
Yeah, and also to,
What's the cost for that?
hopefully not spread more infectious diseases.
Yes,
Yeah.
Absolutely.
Yeah.
Right, yes.
Kind of on the public health radar.
So that amount that you're seeing, Chair, is not just the syringe exchange component,
It's
there's
the
a lot,
whole
it's the whole program.
things.
Yeah, there's the staffing, the wound care, the harm reduction,
Naloxone.
the testing that is taking place, the community resources that
Right.
people are going out into the community to educate, so it's the whole
All
program.
that's prevention.
Yeah, yeah. Which is a great segue into the last slide in my last couple of minutes. So one of the highlights is that we were able to attend a National Opioid Settlement Conference in June and December. This was the first annual national conference. Again, settlement dollars have been around since 2022, but it's really this past year that a lot of things have really coalesced with it. There was the first state opioid settlement summit in May, and then this first national one was in June. And then I believe that at NACO this year, there's going to be a summit as well that many of you are going to be able to go to. And so you'll learn probably many of these same things, these evidence-based practice sharing, which I found really helpful. And also knowing that when you're on the national stage, knowing that locally, we also have our own resources. And for example, the memorandum of agreement with the Attorney General's office that we're required to follow. And there's also on the Minnesota Department of Public Health's website, there's a local public health guide to spending funds. So I think it's really important as you're on the national stage, also knowing we have a lot of robust resources at the local level. And one of the things I kind of want to wrap this up by just sharing a very small snippet of my personal experience is that I'm also a former heroin addict and a person in long-term recovery. And so a lot of these conversations we had at this conference was around prevention, and these conversations about like, what does prevention mean? You know, are we talking about preventing overdose? Yes. Are we talking about preventing people from ever using or misusing opioids? Yes. Like they're both these really strong yeses. And one of the things and most impactful things, I don't talk a lot about my story in my professional life. But there's a woman at the conference and she talked about.
It's the story.
It's a story. And she talks about living your recovery out loud. And so, and I think, you know, you never know who your next deputy is gonna be. You never know who your next change agent is gonna be. You never know who your next advocate is gonna be. And so using that kind of public health analogy of like, we need to be able to have those systems in place so that if people fall in and they're swimming, you know, they're upstream, that we can like pull them out, and that we have those resources. And Ryan talked a lot about his success story, and my success story has some similarities and some differences. Harm reduction, my story is a success story of harm reduction, of syringe exchange, of treatments, and of self-help groups. And so that I'm able to be a person here in long-term recovery and doing this work is extremely important to me. And then I also say, you know, it's also really, really important to look upstream and so catch people before they fall in or jump in. I jumped in. I didn't fall in, I jumped in. And so we really need to have those systems in place with the primary prevention, that youth prevention, and those family supports and those other wraparound services. So.
I just thank you also for taking the lived experience and applying it, and thank you, Ryan. It's invaluable. And for allowing that to inform our decisions. There's a lot in this last slide and the last little bit of informational sources that you hinted at. Ooh, I know that there'll be a follow-up memo to us. Can you include some links to some of those data sources and some of these reports? That would be really helpful.
Really helpful.
And thank you too for taking up risks to say that.
Yeah, thank you for being here and being receptive.
All right.
All right, thank you. So in this slide here, you see that the State of Minnesota Opioid Settlement Memorandum Act emphasizes on the settlement funds to address opioid crisis through a comprehensive community-based approach. In alignment with the framework, Ramsey County established a countywide governance model with the 3 deputies that we talked about earlier, myself being one, DCM Reyes and DCM Francois, and the 3 of us really representing the 3 different areas in regards to health and wellness, safety and justice, and community services and support, and having really that one Ramsey County approach and moving away from the model of what we had opioids under public health, but moving it into a countywide lens to make sure that we're cross-functioning together as one. And then the countywide opioid response initiative, like the funds, it's really to make sure that we go across prevention, treatment, recovery, and harm reduction, while also addressing related challenges such as like homelessness that we talked about earlier, behavioral health, community stability, and making sure that we're investing in informed decision making by collaborating across the county departments so that we're not duplicating our efforts and making sure that we're working together as one. Go to the next slide. And in this slide, it's the structure the new structure that we created that we talked about earlier. So the new governance structure shows 3 different bodies. There's the executive body, which is myself, DCM Reyes and DCM Francois. We provide the strategic leadership, we establish priorities, approve funding recommendation, and ensure accountability for results. Then the second layer is the internal advisory committee. The internal advisory committee includes representatives from 9 different departments within the county. Our public health director, Karen, is the chair, and it consists of these 9 different departments. The committee coordinates across like the department and identifies opportunities for collaboration and develop evidence-based informed recommendations to us, the executive team, so that we can make informed decisions. So that team right there, the internal advisory committee, they're the ones that are going to be bringing forward some of the recommendations that we talked about earlier, like is housing needed? It's harm reduction in other ways needed. It's the hospital part that we talked about earlier, like, do we need to send navigators or do we need to figure out if people need to have some sort of connection to the county? Those are the things that they'll work on, the internal advisory committee, and then they'll bring it to the executive team and then we'll make the decision of moving forward and moving those. And then the last one is the community, and that's coming in future state to support the work that we're doing. So.
Just the community advisory group, I know that's a future state, but are you envisioning that being outside, provider and advocacy groups or specific individuals? I mean, I'm thinking of, our medical community, I'm thinking of like, I mean, families who have kids who are missing school, truancy issues that can be early indicators of mental health or family instability or health. I mean, I'm just trying to think of who are you envisioning being in this, or is it too early to tell?
Chair, Commissioner, we're still working on that, but we want the lived experience, we want the community, we want the health practitioner. Like, we want to make sure that we have a different lens than just the internal processes. So we're still identifying exactly what that looks like in this future state. That's gonna be the next phase.
So it could be some kind of a mix.
Correct.
Of all of those different viewpoints.
Correct.
Okay, that's great.
Can I,
Speaking of this advisory committee, I didn't see anything that touched on like our grantees, our community grantees. If we've incorporated or what some of those results have been or the feedback that we have gotten from them. And also will that help to inform the work of the advisory committee and or the makeup of the advisory committee?
That's a great question. Something we definitely think about.
And then what about like the work of the grantees then? Have there been any updates or?
So, sure, you're talking about the 17 smaller grants that we put out early on. Those were really, as you know, and you gave us feedback on the last presentation we gave, those were very small grant boards of up to $40 or $50,000 for a very short time, period of time. We do have some reports back from them and we certainly can get that to you. Hindsight, those should have been larger grants for a longer period of time. I mean, if you only have 9 months to a year to do something with
at least 3 years.
Yeah. So
10,000 is nothing. It's not even a salary.
Yeah.
Most times, yeah.
So.
Yeah, I mean, I think that's.
So if we move forward, we need to, that process is still a lot different.
Less people, more.
Yeah.
One, and I'll just follow up with this. One of the feedbacks we get from the community is that oftentimes we don't think about sustainability. Like, we provide these short, very small funding that by the time they get things up and running, then they have to think about their next step. So we also got to think about that in the future when we're doing these smaller grants, like that people are going to have some sort of sustainability.
I think data tells us if you want to have an impact and we have an impact, you got to go at least 3 to 5 years. That's across the board, it has to happen. But my hope is that as we look at like this community advisory group here, that you include Ray and you include Ryan. You cannot talk about solutions without talking about those who have lived through this and had an impact. You guys are great, but you don't know. You don't know what you don't know. And I say they know, and so they can bring those experiences to the table. Commissioner,
I just want to quickly add to that point is that, and when we do the community advisory, that we actually have community present, right? Like, I always think community knows how to help community and they've been doing it for years, underfunded, under-resourced, trying to figure it out, right? It's about time we as government start helping our residents and our community members as well. And that first step of helping is listening to what is working in their community and what's not working.
Thank you, Madam Chair. Yeah, thanks for this. I love this chart, the governance, the aspirational governance chart. When I'm thinking on what County Manager Becker said about, it's gotta be leadership that talks about it. So maybe at the executive governor, are you talking to, well, who's gonna be talking to like the higher structure in St. Paul or in our cities on some of these issues? Like we we can do it, but we need it to be totally coordinated with
Yeah,
you.
yeah,
Like, I don't wanna go out and talk to my city, I only have a couple cities that are even getting dollars,
Yeah.
but. I
We'll
just want-
follow up. We'll follow
Yeah,
up
I
with a
just wanna know where that
strategy. Yeah.
connection is, cause
Yeah.
I agree that
Yeah.
that should happen.
Yeah.
Cause we wanna do our part,
Yeah.
but we'll obviously need direction.
Yeah, and Madam Chair, I'll just say with the community advisory group, I just wanna advise us. We've had a lot of initiatives where we've had community advisory
Yeah.
groups. I'll just say it out loud. And sometimes we set the wrong expectations.
Yeah.
I also want to, and I agree with everything about the lived experience. I don't have anything to say against anything you've all said, but what I would like to encourage our sponsors and our teams to think about is we are in a unique moment of very limited resources. We have some things that we are mandated to do. So even when we're working with our community advisory groups, we can keep them into a place of recognizing their feedback and lived experience while also providing some really clear lane of like, we are aligning our opioid work with existing county mandated work that we have to do. I think about the African Preservation Act, for example. There's no reason why some of these dollars aren't actually aligned with the active efforts and framework that we have to do. That is exactly the work. We don't need to find more and more money to execute against things we're mandated to do, if that makes sense. So I like the work around, you know, our people in our care and custody, because that's mandated work, the MAFA work. Like there's just specific things there. They're big things that we can't afford to do a good job without more resources. And we shouldn't use this as like a separate lane. If we're gonna do prevention, let's tie those initiatives together in some way so that we're advancing multiple things at the same time. So if we're gonna be doing some prevention with families, let's make sure it's connected to families who are experiencing, you know, impact on our child protection system. So I hope that helps as you prioritize, as people bring ideas, as you decide on funding. This really is the flexible money we need to offset some of these very serious gaps that we can't put on the property tax.
And can we also just look, as you're thinking about this, that we want to have an impact. So how do you know you have an impact when we spread a little about it out across our space? We're not tracking anything, you know, so just think about how do we go back and say we had an impact? You know, we have 50 subjects, and out of 50, at least 40 or 30 was able to recover or miss, but you gotta do some prevention. I'm not seeing a lot of, and I hear you, you've done a lot, but do some prevention and then track what you're doing too.
I was just gonna quickly add, there are community organizations that are doing a lot of this great work and this preventative work to uplift the whole family, right? To change like poverty, to build intergenerational wealth, right? To change people's like trajectory. So really look in and lean into them and the work that they're doing and how that cross works.
You know, we just did all.
Yeah.
They're doing awesome work, sometimes on a very small budget.
Yeah, a very small budget.
Transforming lives every single day, and so let's try to do that with expectations.
You all knew me with the budget and with operational excellence and all of this, and so I am completely in alignment with One Ramsey County and not siloing and to leverage our activities and to look for opportunities through our community engagement work with our youth justice transformation work and other areas where we are in community and not overtaxing the folks who are showing up in community to be our trusted partners and all of that 100%. And I will push a little bit on the idea that even in this most devastating of budget times, these dollars were dedicated to address this specific harm. And I think we can look at that in broad terms as far as prevention and families that are impacted and know that there are many things that are interconnected, and all of those things are true. But in a time where we are having limited dollars and these seem to be unfettered, I just do not want these diluted as a budget stopgap without intentional decision making as to where. And I don't think that was the intention of that, but I just want us to be thinking about that multiple things can be true at the same time. That the very families that we're trying to get into stable housing and food security and to address during our child protective services and all of it are also probably and most likely also impacted by substance use disorder. And so it is a natural entryway to be doing those preventative services, as long as that's what we're doing with these dollars.
And so we've come to the time end. I'm gonna say two things only. In all these notes and all this conversation.
Show that last.
We got
I
another slide.
think the very last, just a reminder of the budget.
Show the budget.
Well, I wanted to show you how we leverage the budget in 27 because that's gonna come pretty relevant for you. Especially as you went through the addenda process in particular, to bring down the levy a bit, but you're seeing the housing, so I'll let you kind of
Yeah.
finish up, but.
Yeah, so in this last slide, what you see in front of you is what we have, the funding that we have used in 2020, 2027 to address the budget and where it went. The detox withdrawal management to help support the next step and next phase of that. The housing department in regards to making sure like that the funds went there to support the work that is being accomplished there. And for the 451,000 for the appropriate response initiative, it expands the alternative that connects individuals and experience behavioral health crisis to the right services at the right time. And then the last one is the one we just discussed earlier. We got a really late notification in June that this program will come to an end in July. I think it was like a matter of like a week or 2 weeks or so. So the syringe program, currently right now, what we did is we utilized some funding to address that issue for the 2026-2027 budget so that we can assure that that 1 year, it's a bridge funding following the loss of the state funds and figuring out like long-term solution. So if you look at like all of this, like I look at this in like terms of like collaboration and strategic coordination that we have to do, and also like learning and continuous improvement. So when it comes to the collaboration and the strategic coordination, at this work continues to evolve, right? Like we have to figure out how to strengthen our coordination across departments that are aligned, our investment, reduce duplication. That's the major thing that we're trying to really look at, and maximize the impact of every settlement dollars. We're also looking to conduct an countywide inventory of the opioid-related services and continuing work with local jurisdictions that we talked about earlier and region partners, like really coordinate those strategies, leverage resources there, to really better serve the community that, togetherness. And then the learning and continuous improvement part, like I would just say Ramsey County's leadership and staff are actively participating in state and national forums that we talked about earlier to ensure that the work reflects the emerging best practices and lessons learned. Participation in local public health associations and settlement strategy summits that the team have gone through, and all the other resources that to ensure that we identify the innovative ways to approach preventative work, treatment, recovery, and harm reduction. And I'll just say in closing, like these investments demonstrate Ramsey County's commitment to responsible stewardship of opioid settlement funds, are focused on making thoughtful, evidence-informed investment that improves the outcomes of today while building a stronger, more sustainable response for the future. We're at a cross path where we're looking to see how we can address some of our concerns internally as a county and not duplicate our efforts versus how do we tackle the issues that the community is having at the same time. So they're like, these are two things that are right at the same time, and we got to figure out like how to do it together. But they're extremely important because as of today, not just I'll take back from a federal standpoint, right? Like we're going through some extreme things with the current administration. So we really got to look at how do we not continue to tax our county? How do we address our internal issues that we're having with the budget and figuring out how to not duplicate some of our efforts? Also, how do we address some of the work that we're doing by utilizing these funds? And then also, how do we support the communities that are doing great work by not giving them some crumbs and giving them sustainability to do some of the work? So it's really a tough road to be in, but I think myself and my other colleagues, the two DCMs in this strategic executive committee, along with our county manager, will have these discussions. We'll figure out the path. We will establish more conversations with the cities and figure out how we also partner, because for so long, we've been in siloed and we've probably been doing the same thing in two different cross path, and maybe if we can combine some of our funding, we could do certain things, because the same clients may be surfacing in the same places, so we gotta figure that out too. So we appreciate your time today, the conversations, the questions, and the feedback that you've given us, and look forward to continuing this work. And I know there's been a lot of questions asked, but if you have any more, I'll let you maybe have that opportunity. But before I close, I missed this in the opening of my remarks, but I wanted to make sure that I give a lot of thanks to the group that's back here, because I know that a lot of this work will not be without them. So they have been doing a great job. It takes truly a village to do this work. And I just want to say thank you. And with that, we'll stand for any other last questions.
So what time we in? 3?
We're done.
We're done, okay. So I'm going to end with this, is that I'm gonna take, I think it was Ryan's words that said, in dealing with opioids, is that residents' worst day must be met with county resources, support and care. And so as we continue to build this infrastructure, we know how critical it is that we try with limited resources, pull back from the federal government, that we do this in collaboration with. Right? And I definitely would say that those who've been impacted in community-based organizations that has been doing this, because many lives depend on this. So I just want to thank you all for your work, for your service and the work that we have done. You know, let's look at the learned lessons and how we're going to move forward to do this and bring a prevention lens into this in a bigger way. So thank you all.
Thank you.
Legal follow-up
Thank you.
one-on-one.